Morning, good noon, good afternoon, good evening, good night. Hello, everyone. Welcome to the Thursday edition of Virtual Morning Report, where I have the distinct pleasure of hanging out with Priyanka, Sukriti, Rafa, and of course, the one and only blush vulnerable Charmeen Chikarchan. There's no blush today. Wow.
I'm no Jack Penner. What are you talking about?
No, I don't know. I think you've forgotten the days where you were very much like Jack Penner, and now you're like the ultimate boss lady. No blush, no more.
I see I'm getting challenged
A
to
little bit,
blush.
just a little bit. Welcome everybody. We are slated to do our regular, which is to have a volunteer for a case, and then two volunteers to join us in the discussion seat. And we have a very, very strong preference to have folks who do not identify as men to join us to elevate everybody in clinical reasoning. So if you have a case, please volunteer to present. If you would like to join Charmine and I in the lukewarm puppy bed, yes, oh, don't do that. Yes, I am sitting on a puppy bed. I am here with my 3.5 month old puppy, and I am sitting on his puppy bed on the floor. So if you would like to sit next to me on a puppy bed and play with the puppy for 50 minutes virtually, please volunteer to discuss. All right, I'll pass the mic on to Charmine to reflect.
Thanks, Robbie. I can vouch that the puppy is adorable. Uh, Yesterday case was awesome, and it was discussed by the esteemed that three incredible S's, Sonia, Sherry, and the wonderful Steph Sherman. And they did such a fabulous job that this S cannot do it justice. But I'm just going to share a couple of reflections. The case started with a 62-year-old man who was presenting with pleuritic chest pain and cough for about 3 months. And in the background, we had like 30-pound weight loss and a right facial droop. So usually what happens, with they did a great job of like going through the chest pain and thinking about like, we always want to start with our no misdiagnosis, especially in the beginning, we didn't have that 3 month history. When I think about pleuritic chest pain, I think about like, okay, there is pain with pleura moving. So what is sitting next to the pleura? So is it something in the lungs that is making the pleura a little angry? Is it something in the chest, in the a form of like cardiac pathology like pericarditis, mediastinum, and then not forget the thorax neighbor abdomen. Um, and I think, the center tends to be like what's the most common, being a lung pathology. So having that in the background, understanding of also someone who is endorsing cough as well. So thinking about like what pulmonary pathology could be going on. And the time frame is incredibly helpful. So we know that we're not dealing with like most likely an acute bacterial infection that going on for 3 months in the background of weight loss, that is something more subacute to chronic going on. So something a little bit more insidious, where it would be malignancy, an infectious etiology, or an autoimmune pathology. The right facial droop always makes me pause because my mind goes to Bell's palsy. But in the context of someone who's coming in with kind of more kind of like systemic signs, and also like giving a flavor of multi-organ involvement, it's like worth considering the rare causes of facial nerve dysfunction. So Bell's palsy being the most common, about 70% tends to be unilateral. A lot of the time, we don't know what causes it. Versus some more rare causes like infectious etiology, viral, like HPV, VZV can do it, like autoimmune diseases like sarcoids, and then like other etiologies like amyloidosis can do it as well. And also thinking about some compressive pathology as well. So, it's no surprise that even with a facial nerve, we want to kind of think about our three favorite buckets of more chronic issues like autoimmune, infectious, and malignancy less likely in this etiology. So off of the bat, like we're thinking about infection and autoimmune diseases. On exam, what we saw that was interesting was like bilateral MCP joints that was swelling right greater than left. And there was an incredible discussion by the team about whether this is like noise or signal. Is it part of this multi-system pathology versus that it is separate from each other? We thought about like rheumatoid arthritis for a while that can both have like lung pathology. But like again, like the nerve involvement would be a little bit odd for that. When we got to the labs, we saw a UA that had RBCs and also some chest CT with long nodules and some cavitation. And we thought about like pulmonary renal syndrome. And when it comes to pulmonary renal syndrome, my favorite is that, I always forget about the most common causes and I jump into autoimmune versus like the most common cause is actually your pneumonias, right? That cause pre-renal, or your heart failure that cause AKIs because of congestions. But absolutely, they're like more rare causes that we love, right? So thinking about like what affects you, both your lungs and also your glomerular. So that is like your glomerulonephritis, like ANCA, anti-GBM pathology, lupus, cryo. And then like the things that can affect interstitium, that is like your legionellas or your sarcoid pathology. And one of the most striking one is scleroderma that can both affect lung pathology and also cause a renal crisis as well. And the RBCs are really helpful because it makes us think about the glomerular pathology as well. So at this point, someone coming in with cavitary lung nodules, most likely glomerulonephritis, really made us focus on ANCA vasculitides. I love how when Sonia was zoning out, she has like his lungs, his kidneys, his neuro MSK. And like those pattern of disease, in addition to a C-ANCA and an anti-PR3 that came back positive, made us hone in on the diagnosis of GPA. And the patient also had some nasal involvement as well, which was fascinating. It was a fascinating case, great review of autoimmune etiologies of both cavitary lung lesions and also multi-system diseases. I mean, as someone who loves vasculitis, it was a great discussion. That's all I got, friend.
Oof, a walk through the lungs, the nerves, the kidneys, the combination. Ay, ay, ay. There's no fire emoji, and there should be. That's my summary of your reflection. No
You can show NAR.
Oh, that's right. My puppy's name, I forgot about that. It's kind of embarrassing. My puppy's name is Nar, with Naar, which means fire in Arabic. It was based on watching him play at a video that was sent to me, and the name couldn't be more true. He's a lot of work and constantly on hypothetical fire. Yeah. Oh wait, Paul, how'd you do that? Anyway, I'll learn someday how Paul did that. Charmaine, we have a case, and we should be riddled with anxiety, the fake kind, because it's Gabrielle who will 1000% stump us, and we know that already. So we might as well have fun along the way. So Gabrielle, please unmute yourself. Remind us a little bit about who you are, where you're calling from the world, and please tell people how amazing your cases are, which you probably won't. So they jump in and discuss with us.
Hi everyone, my name is Gabriel. I'm from Lima, Peru. I'm a MS2 in Lima, in Cayetano, and very excited to be here today with you guys. I encourage you to discuss this case. Actually, this was presented by me by a friend who is IM resident in Lima, and I discussed this case with him yesterday at night and learned a lot during the process. So I can assure this is a very interesting case, and hope you motivate.
I learn so much every time you present a case. So I cannot wait to learn more from you, Gabrielle. It's going to be epic. Who wants to join us? It's going to be real fun.
Gabrielle, if for some reason you decide medicine is not your thing, which would shock me to my very core, you have a career in marketing waiting for you. Guaranteed, 100%. That was really, really well done. I'd say, Charmaine, given the incredible power of Gabrielle's cases, if nobody wants to jump in and discuss, what we might do is you and I can discuss, and we can elevate voices in the chat and call on people.
Sounds great.
You're thinking. Why don't we do that?
Let's do it.
All righty. Okay, Gabrielle, please take it away. And Charmin, I would love to always follow in your footsteps. Take the lead, please. Take the lead.
I'm not sure that's gonna end well for you, but let's do it.
Um, could I start? Okay, so this is a 39-year-old male who presents to the ER because of headache and fever.
All right. Is this a good place to stop, Gabrielle?
I think so.
Sounds great. All right. 39. Young. That's the first thing that jumps out on me. Coming in with headaches and fevers. So again, when I think about like young patients, and it would be helpful to get a little bit more background to see like, hey, if this is a person who hasn't been in healthcare, has been relatively healthy, or someone who carries a lot of medical history with him. So when he's coming in with like headaches and fever, the question when you put those things together is that like, hey, is the CNS focus of this pathology? Is whatever is happening that is manifested by headache and the fever localizes to your CNS? Or is headache just like is a secondary symptoms of what else going on, and we're dealing for a bit more of a multi-system disease? When I think about headache, it's the same way I think about diarrhea, right? Like abdominal pain. If your abdomen, for whatever reason, is stressed, it manifests as diarrhea. Sometimes it can be the primary pathology, but sometimes it's just, your body's reaction, and headaches as well. People get headaches from like not having caffeine, or from that to like all the way primary headache pathologies like migraines. So I think one thing that with more history would become more clarifying whether where is the center of gravity of this case is, as Robbie likes to say. Is it the CNS or is it somewhere else? So that are my initial thoughts, Robbie. What else?
I'm going to walk in your footsteps and I'm going to be like, wow, it looks so amazing over here. I have nothing to add as per usual. Trying to see what wisdom the chat has to offer. And I really, really love how people are so excited that this is a inflammatory syndrome. And we're talking about the famous IMAID and its modification mnemonics. And I love Paul's point. How long a fever is going on for is very, very important. In fact, really, when somebody is inflamed, we ask 4 questions. And those 4 questions are understanding the who the patient is, what is the syndrome here, fever and headache, when, the time course, and where. And the where is the final part of it, I think, that is easily overlooked, because where the patient is in the world determines what kind of inflammation they get. Now, you can live anywhere in the world and be vulnerable to cancers. You can live anywhere in the world and be vulnerable to autoimmune diseases. The where is more what infections are at play. And we know that Lima, Peru is very different than San Francisco, California. So we'll love to learn more about that in addition to the when. All right, Gabrielle, back to you.
All right. So Ole started 2 months before when he reported fever, and 1 month before the headaches started. 3 weeks before, it was very interesting because he reported hearing voices. He reports a demon that tells him to kill himself and escape from his home. He has lost weight in the process, but doesn't know how much. In past medical history, he was diagnosed with pulmonary TBC in 2005. And in 2010, he was diagnosed with schizophrenia. In meds, he's taking olanzapine 5 milligrams, but the mother refers that he was very inconsistent with the treatment, but he started to be consistent with it 5 months before presentation. And family history, no social history. He was from Cajamarca, that is a region of Peru that is located in the north. Health-related behaviors, no drug use, no alcohol, and no medical allergies. Um, is there anything you want guys to know?
I think this,
The
no, go ahead, Mr.
I could give you sorry, the headaches were more predominantly in the occipital region bilaterally, and they were pulsatile in the in it was a pulsatile like characteristic.
I think this is a good place to stop, and I'll just I'll actually leave the syndrome before you for Charmaine to teach you about. And I will say that this comes up a lot when we say the patient is not a good historian. I think that's I think that label is not only judgmental of the patient, which we should try to avoid, though we're all human beings and we all are vulnerable to that when we're tired, exhausted, etc. But I think that it actually is a setup for diagnostic failure when you say the patient's not a good historian. Because I think, to put it bluntly, I think it's lazy diagnostics. It fails to answer the question, why is the quality, the perceived quality of the data as it evolves from the patient not as good as you could have seen it being? See how there's a lot of judgment there. But often when we talk and we collect a history, we make a value judgment. Is this history logical, linearly organized, prioritized, etc.? And the human mind has a great ability to understand what is happening to its body and triage the chief concern amongst all the possible concerns, describe a time course, and really keep a close eye on the rest of the body. And when we are falling into the trap of labeling somebody as a good historian, what we're doing is we're being lazy about why the brain has lost its ability to keep track of the data so well and so accurately. So for me, whenever I'm falling into that world, I have to ask myself, well, why is this happening? And is this happening because the patient has cognitive impairment? Is this patient happening because there's a substance on board? Is it happening because there's social stigma around what the complaint is and the patient doesn't want to tell me? So you really, really translate poor historian. And if you're being unbiased and have your diagnostic acumen trying to be ramped up to the max, you translate that into a form of altered mental status, really. Because what is a good historian? A good historian is, one, we are the historians. It's you collecting the history who's turning it into a narrative for your diagnostic purposes, not the patient. But practically speaking, just to avoid the confusion around the terminology, is if a patient is unable to keep track of what is happening to them, that different than what you'd expect, and how is that different than a form of encephalopathy? It's a unique kind of encephalopathy that also carries with it a lot of additional features like social stigma, social pressure, access to care, etc. And I think that's the question that has to be answered here, is why was it hard to get this history from the patient? And I think that is actually a fundamentally crucial part of the diagnostic exercise, which I'll pass on to Charmaine. So to summarize, no patient is everyone is, you are the historian, but if a patient's not telling you a cohesive narrative, there's a reason for it. And don't be lazy and just ascribe it to the patient as somehow deficient in some way, shape, or form, but try to find why you're picking up a deficiency which you should try to address and help them.
I think that is the most important lesson here. Thank you so much, Robbie, for sharing. And I feel like a lot of patients with primary psychiatric disorders, medical care for them is quite challenging. And I think there is a lot that we can do better and a lot that we must do better. So thank you so much for that. That means a lot as someone who has a family member with schizophrenia. So that means a lot. So in terms of the syndrome before us, I think the weight loss, it's such a good trigger to always that tells you about the pathology at hand, is that this has been going on for a while and something to take seriously. And it has, the differential is really, really big, but it just kind of tells me that, hey, this is something that is going on, whether it's infectious in etiology, whether it's autoimmune, whether it's malignancy, to take quite seriously. And with the neo-occipital region headed by lateral and pulsatile, again, I don't know if I can make too much diagnostic progress with this headaches. Other than that, if it's new, then it makes me think about like secondary causes a little bit more about what else is going on with this patient. And in terms of like the hallucinations, as mentioned, like it is a part of this schizophrenia illness script, is that patients do tend to have some auditory hallucinations. But then again, like, people can be compensated and decompensated, like in like your heart failures, when it comes to psychiatric diseases as well. And what triggered this discompensation is the first time this patient's having a hearing, is the first time he's hearing voices. Then again, you want to think about also the organic causes of it, and not just focus on this being part of the illness script. Or if it's a decompensation of it, why the patient is getting decompensated? Is there anything that we can help with? So for now, it tells me that this is kind of a subacute to chronic presentation of probably center around an inflammation, CNS versus multi-system. And in the background of it, the pulmonary TB, it would be helpful to know that if this patient was treated or not. But again, like, we love TB. TB can go anywhere and do anything. And if TB can do it, histo can do it better. So I think chronic infections should definitely be in mind, as also Robbie mentioned, in terms of the health-related behavior in someone who can be marginalized because of their psychiatric disorders, thinking about like, STIs, thinking about HIV, also it's a good practice. And the medication that jumps out to me, olanzapine, an antipsychotic, it has a lot of like metabolic risk factors and can cause metabolic syndrome. Rarely it can cause hematological issues like neutropenia. So another thing to keep in mind, as a medication who can be really great to control the primary psychiatric issues, but also can cause a lot of side effects, unfortunately. So I think exam hopefully will be helpful in helping us like focus, like, is there any other organs involved, or should we just go investigate the CNS a little bit more, do a complete neuro exam, think about like whether we need further imaging of that, or, LP, which should be our bedside procedure. Is how I'm thinking through this case so far. And just like your alto mental status, if for whatever reason you can't get your specific questions answered, then your objectives needs to be more complete. So more thorough neuro exam, making sure you look at the back, the skin, more labs most likely, so it allows you to put a better picture together. Any other thoughts, Robbie, before we move on?
Where is that fire emoji, Paul? Where is it? Absolutely brilliant. I'm nothing down.
Yes, Ravi, thank you for saying that, because patients with schizophrenia and other mental disorders, taking history and searching for more pathologies is kind of hard, because usually physicians think this is only schizophrenia and they stop searching for another clues. Just for clarifying something in the medical history, past 2 months, he was having visual hallucinations too, at the demon image, and he also refers that people were searching for him, and like they wanted to go to prison. He was having those ideas before that. And in terms with vitals, he presented to the ER actually a febrile 37 Celsius, respiratory rate 20, heart rate 92, pressure 120 and 60. General appearance, he looks very skinny, and cardiovascular normal. Pulmonary exam also was normal. abdominal exam, normal 2, and in case of the neuro exam, the Glasgow was 15/15. No Korninski signs, no Brudzinski sign, no signs of focalization, no nuchal rigidity, and in the skin, no rash was noted. No hepatosplenomegaly also. Maybe I could give you the labs too, because to have something more to discuss. Let me search. Hemoglobin was 13.3. Median corpuscular volume was 82. Leukocytes were 7,000. Platelets were 211,000. Neutrophils were 65%. Eosinophils were 5%. Lymphocytes 20%. Glucose was 100. Urea was 20. Creatinine 0.8. Calcium was 15. Sodium was 143. Potassium was 5. Chloride was 105. Albumin was 4. PT, prothrombin time, was 16. INR was 1.2. Total bilirubin was 0.4. Alkaline phosphatase was 80. And GGT was 22. They also did HIV test, which was negative. Hepatitis B was negative too. They did some syphilis tests, BDR, RPR negative. And they did acid fast, but as acid fast, I don't know how to say, like tinción acid fast, but it was negative. Searching for acid fast bacilli of the sputum was negative. And in terms, maybe do you want guys to stop there, and in the next aliquot I will give you the other exams of the images and the
Sure.
LCR. Okay.
Yeah, absolutely, Gabrielle, you're the boss. Absolutely. I always love when you present cases because I feel like I get my diagnostic reasoning gets pushed to the limits of it, and I love it. I think like just going back to the visual hallucinations, I really think that's such a valuable piece of information, and thank you for sharing that. I actually learned from Robbie that, when people have auditory and visual hallucinations, those two places are not close to each other in the brain. So it makes you more worried about more systemic metabolic encephalopathy, like encephalopathy in general. If patients having both like visual hallucinations and auditory hallucinations. Even in this case, if we say like, hey, let's just make the assumption that this patient's auditory hallucination is part of their primary psychiatric disorder, then with the visual hallucinations, anything from like migraine from aura to occipital seizures to things that cause the decreased mentations, like your dementias or metabolic encephalopathies, toxins, like, alcohol withdrawal, those things can all cause visual hallucinations. So that's just another point for, hey, whatever is happening is causing encephalopathy for this patient, is how I'm interpreting that. And I'm actually gonna, since I'm tired of hearing my own voice, RG, do you want to take us through the exam and the labs?
Oh, okay, you got it. So I think that when you're in the realm of an encephalopathy, the question is what kind of labs, what labs will be of prominent significance. And I think that the focus is often on infection, but you really, really have to step back and be like, what metabolic processes might you be dealing with? And that's where your reminder to make sure you get a calcium, because it's so easy, at least in my hospital, to not click that magical button. And here I think that the prominent abnormality is, in fact, the hypercalcemia. And the hypercalcemia is very severe. We often stratify hypercalcemia as mild, moderate, severe for treatment purposes, but also for diagnostic purposes. The higher the calcium, the less likely it's a benign process like hyperparathyroidism, and the more likely it's malignant. But let's start with knowing that the base rate is determined by the height of the calcium. But if you are systematic about it, you'll recognize that 3 hormones are the principal effectors of calcium. That's PTH, PTHRP, and vitamin D. So often when I see a calcium that's high, I ask myself, is it driven by PTH, PTHRP, or vitamin D? And the most confusing one is vitamin D, because it's not any vitamin D that causes hypercalcemia. It's the 125 hydroxy vitamin D. And the 125 hydroxy vitamin D is elevated because you take too much 25 hydroxy vitamin D from the world, or that you convert too much in the form of a granulomatous disease like tuberculosis. So how can we make progress? We can make progress by looking at the phosphorus. And unfortunately, we don't have that data here to analyze the chloride to phosphorus ratio. And how does that helpful? Parathyroid hormone reduces phosphorus, and the effects of PTH. Oh, the phosphorus was 2, which is very low. And the chloride I can do a little bit of math. 105 divided by 2 is way more than 30. So the chloride to phosphorus ratio is suggestive of a parathyroid mediated process, though it's not definitive. It's pretty good, but not perfect. Yes, as Paul reminds us, it's the phosphate trashing hormone. And so what PTH does is it elevates the calcium at the expense of phosphorus, in contrast to vitamin D, which elevates both calcium and phosphorus at the same time. So here you wouldn't stop with assuming it's PTH, but you certainly would just get that test and see what it is. So the next key question in this case is, what is a PTH? And the support for PTH is the chloride to phosphorus ratio. But as Mario brings up in the chat, it also could be an effect of PTHRP. So for me, I think this case is really boils down to what is the PTH. And if it is elevated, which the chloride to phosphorus ratio suggests it might be, then the next questions would be, there's actually 2 branch points. If the PTH is high, then you have to ask, why is the hypercalcemia from primary hyperparathyroidism so severe? And it might be because it's so advanced and undertreated in this patient. It might be because the patient has had lithium in his past as part of the treatment of schizophrenia, but that'll be an important question. The most morbid cause of a super high calcium from a super high PTH is parathyroid carcinoma, which is rare, usually familial, and a very important consideration. So to summarize, for me, the labs translate, this whole thing translates into what is the PTH. And if the PTH is high, are we dealing with advanced untreated primary hyperparathyroidism, or are we dealing with parathyroid carcinoma? And if PTH is low, the question is, what is the PTHRP? What is the 125 hydroxy vitamin D? Is there ingestion of calcium in the form of milk alkali going on, which the bicarb is a clue for? And is there metastatic disease to bone? So really, I'm very eager to hear what the PTH is next.
Yes, PTH was 95, which was elevated. normal values from the lab was less than 50. Phosphorus was 2. And in case of the cerebrospinal fluid, the opening pressure was 10. Glucose was 33. Proteins was 117. India ink test negative, gram stain negative, acid fast stain negative. They ran some fungi cultures and bacterial cultures for the cerebrospinal fluid, but all of them were negative. And they did an X-ray too that showed no abnormalities, no apical consolidation this time. They also did an EKG, no abnormalities too. And they did a MRI that showed signs of meningitis in the interpeduncular cistern and right prepontine. Yeah, that's what I saw in the images. And do you want guys to comment on that? And I could finish.
Yeah, this is a great place. I just want reflection, Gabrielle. Do you know what the CSF white blood cell count was and what the differential was?
Yeah. I think I have it. Let me see. Leukocytes 88, and all of them were neutrophils.
Okay, wow. So 88 and all of them were neutrophils. Surprising. So what I'll do is maybe I'll just study the elevation in the CSF and then leave everything else for Charmaine to reflect on. And so when you see a pleocytosis in the CSF, the differential is very, very important. And the reason it's important is because at time 0, you don't have any microbiological data or any data that's definitive of diagnosis. You don't have cytology back, you don't have autoimmune antibodies back. And so what you do is you try to study what is happening based on the body's response. And how the body is responding gives you a clue as to what the diagnosis is. So there are 3 prominent types of responses in the CNS. There's a neutrophilic response, there's a lymphocytic response, and most rare and most intriguing of all, and most fitting with the Gabrielle case, is an eosinophilic response, but that we don't see here today. The response is a function of time. So you have to be very careful about where you are on the time spectrum. And what usually happens is a neutrophilic response will stay neutrophilic the whole time. A lymphocytic response will actually begin as a neutrophilic response. So the first question when you see neutrophils is this going to be a pure neutrophilic, persistent neutrophilic process, or is this somehow going to translate into a lymphocytic process in the near future? And that's when you have to go back to the time course. And the time course here is actually protracted. So if it were going to be lymphocytic, it would have been lymphocytic by now. And it's not. So we look at this, we're like, we'll see it's all neutrophilic. And then the other question is, well, what is the height of the neutrophils? Because pyogenic bacterial meningitis is a neutrophilic response, usually in the thousands, not 88. So I think a pyogenic bacterial meningitis, usually strep pneumo, Neisseria, and Listeria, is much less likely. Did you see what I did there, though? Without even being clear and explaining it to it, I jumped right into infection. That's because neutrophilic pleocytosis in the CSF is virtually pathognomonic of infection. There are some autoimmune and some malignant conditions that can do it. The autoimmune conditions that can do it really are Behçet's and neuromyelitis optica. Not very likely here. The drug-induced neutrophilic pleocytosis is described with Bactrim and things like that. And actually, meningitis can do it, but a very unique kind of malignancy, excuse me, not meningitis, a unique kind of meningitis by cancers in the brain that leak oily material and cause neutrophilic pleocytosis. So if your patient has a craniopharyngioma or a epidermoid cyst in their brain, that can cause a chemical meningitis and result in a neutrophilic pleocytosis. So neutrophilic pleocytosis is usually infectious. And the height of the neutrophilic count tells you that it's either bacterial, pyogenic bacterial, or not. What other things can cause a neutrophilic pleocytosis? Well, other bacteria, things like tuberculosis, brucella, nocardia, etc., the atypical kind, and these usually cause a much lower neutrophilic pleocytosis. Then there are molds that can do it. Things like aspergillus and mucor can cause a neutrophilic pleocytosis. Viruses, but very early on, so West Nile, HSV, etc., but those usually will cause an early neutrophilic pleocytosis that then transitions to a lymphocytic pleocytosis. But you cannot forget the horrible flesh-eating bacteria, Naegleria fowleri, that can cause very bad neutrophilic pleocytosis. So to summarize, PMNs in the CSF, stop and ask what's the time course. If it's acute, they might turn into lymphocytes, so be careful. Here, not the case. Then recognize that neutrophilic pleocytosis is much less likely to be non-infectious, unlike lymphocytic pleocytosis. There are some non-infectious considerations, but the list is low, and the infection spotlight is really focused on pyogenic bacterial infection. That's when the height is helpful. Here, the height is low, so pyogenic bacterial infections are unlikely. So are we dealing with an atypical bacterial infection, a mold, or a viral infection? And here, the risk factors for mold disease is absent. Most patients with mold disease have diabetes or neutropenia or stem cell transplantation. So the spotlight is on either a viral infection or an atypical bacterial infection like tuberculosis or brucella. To you, my friend.
Oh, that was fantastic, Robbie. Thank you. Yeah, I'm right there with you. I think the neutrophil, I was like, whoa, neutrophils? I did not expect neutrophils. But I agree with you. Just like going back, this patient is 39 who came in with fever and a headache as well. And so thinking about, we went through this journey with the calcium being elevated with PTH mediated. So with that CSF, I agree with you that I'm most concerned for TB in a patient who's had this history of pulmonary TB in the past. Looking at the MRI with the signs of meningitis, I think the interpendicular cystine is kind of little here in the brainstem area. Correct me if I'm wrong, people. Neuroanatomy, not my strong suit. I'm thinking about more like kind of like the brainstem involvement with like the brainstem pathology. You want to keep a close check on the neuro exam, because a lot of the time people do develop some neuro deficits involved as it progresses. So that's something that I would keep trending. And the LP as well, as Robbie mentioned, LPs can change. So anytime if you find it confusing, don't be scared about repeating your LP studies. But when I think about the meningitis, kind of like this calcium, it makes me think like, hey, is there two etiologies leading to that elevated calcium? Is it part of it that is maybe a glomerular disease, granulomatous disease, #ESL, that is causing that calcium to be elevated? This because we want to explain the fever and we want this long chronicity of the background of weight loss in somebody who has had a pulmonary exposure of TB in the past. Even if the acid fast is negative, it doesn't rule out more systemic TB manifestation. So that is where I'm at, Robbie. I don't know if you have anything else.
I do not.
Yep. Very fascinating case. I'm very curious. That calcium is really throwing me off here. But hey, patients can have multiple things going on with them.
Just for clarifying, I said in the right prepontine region. Yeah, sure. So they did a PCR for the cerebrospinal fluid, and it was positive for Mycobacterium tuberculosis. But right now, the patient is doing interconsult with the endocrinology service, searching for primary hyperparathyroidism and investigating if the patient will be candidate for surgery and ruling out also malignancy. And the patient also is having an interconsult with psychiatry to improve his treatment. And yeah, sorry for presenting TB meningitis. I know this is a topic that has been talked a lot in the VMRs, but I think this case was interesting because I didn't know that primary hyperparathyroidism could present as psychosis too. And it was very interesting to the presentation of the background of the schizophrenia because, as I said, physicians could like overlook this mental disorder and said, okay, this is just a schizophrenia flare, and don't search for other etiologies too.
This was such a great case to walk through. I absolutely loved every moment of it. Thank you. Thank you for presenting. And we can talk about TB all day, every day, and still have more to talk about it. So thank you. And Robbie, any reflections?
No, I think it's just so humbling, honestly. Like this is such an incredible organism that like you can have it 10, 15 years prior and it's in your lungs and it show up in your brain elsewhere. I think that's just mind blowing how an organism can do it like that. And I think it's also humbling to recognize that even if you find a systemic cause for altered mental status like the hypercalcemia, that doesn't mean you're immune to a intra-brain cause like tuberculous meningitis. And I would say that I think the biggest reflection is what Gabrielle just reflected on, um, how you have to recognize that patients with a variety of disease processes, be it substance use disorders or psychiatric conditions, which are usually interrelated, are so much more vulnerable to mistakes by us and so much more vulnerable to us failing them. And so if you do anything, that should have you be hyper aware of that possibility as you go forward. Yeah, thank you so much, Gabrielle. It's always such a treat, really, to learn from you and to reflect from cases from you. And you can see and judge by Rafa's long list of teaching points that we were in for a treat today. And I'm excited for him to take us through that journey again.
First, thank you, Gabriel. Like, there is no CPS without TB. Another thing, just a curiosity, I once had a class that the only place that TB was not like scientifically proven to exist until now was the hair follicles. Every other part of the body was already proved to have like some kind of TB manifestation. So we had a young male with headache and fever. And first we thought about the primary and secondary causes of headache. Primary could be migraine with pulsating pain with photophobia, phonophobia, cluster like periorbital pain, but other signs as well like lacrimation, rhinorrhea, and tension headache, like a steady bending-like pain, which is due to stress. And then there is secondary headache, which could be due to infection, malignancy, and since this patient had a fever involved, we were thinking about secondary headache from the beginning. So when it comes to fever, Rabbi always teaches us to think about 4 questions, which is the when, the time course, what, the clinical syndrome, who is this patient, his past medical history, and where, which is the epidemiology. And then we talked a little bit about hallucinations, and then Charmaine reminded us that auditory type is the most common schizophrenia. But we have to think that when these patients are presented with hallucinations, we have to remember that is it the compensation of the disease or it's unrelated new hallucination? For example, if this patient is presented with visual, it's much more common with drug intoxication and other medical illness than psychiatric illness. And then we saw that that the vision and auditory hallucinations combined, there are different regions of the brain that are involved, we have to suspect about systemic causes leading to encephalopathy. And then we talked a little bit about olanzapine, which is an atypical antipsychotic with fewer EPS and anticholinergic side effects than the typical antipsychotics. It can be used in schizophrenia, bipolar disorder, OCD, mania, Tourette syndrome, and there are many side effects like metabolic syndrome and QT interval prolongation, which can lead to torsade. And then finally, we talked a little bit about hypercalcemia, which Rabbit taught us that it could be involved with PTH, like hyperparathyroidism, which is always great to see the phosphate because it's the phosphate-thrashing hormone, and so there is low phosphate. Also PTHRP, which can be seen in, for example, squamous cell carcinoma of the lung, of the kidneys, and also vitamin D, for 125 hydroxyvitamin D intoxication or activation of vitamin D by processes like sarcoidosis, TB, and then finally ingestion of calcium, for example, alkali syndrome. And then one pearl that Rabbi taught us is about the neutrophilic leukocytosis in the CSF, which is almost pathognomonic for infection, and there are a few exceptions like craniopharyngioma. So thank you, everyone. I hope everyone had a good time, and I hope to see you guys tomorrow.
Thanks, team. Have a great rest of your day. Bye. Thanks, Rafa. That was great.